You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for September 19th, 2025. This week, a couple more trials at ESC. This includes Parachute, DAPA ACT heart failure, Amalfi, and also a super interesting modeling study of when to start oral anticoagulation and atrial fibrillation. So the first topic is the first evidence of treatment benefit in Chagas heart failure. That's the title of the news story. The study was called the Parachute HF trial. Sacubitril valsartan, brand name Entresto, has struggled to find a positive trial after Paradigm HF, which compared high-dose sacubitril valsartan to medium-dose enalapril in patients with HFrEF. All other trials with sacubitril valsartan, including Paragon and Paradise, have been non-significant. At the ESC meeting, we heard results of the Parachute HF trial, and this was sacubitril valsartan versus enalapril in patients with Chagas cardiomyopathy. The results were positive, but there were many caveats to discuss. And even if you don't see patients with Chagas disease, it is worth dissecting this trial for its critical appraisal lessons. Sadly, I think it may also tempt you to be a bit cynical in the process. So first, I'll do some background, then the trial design issues, then the results and interpretation. So the background, Chagas cardiomyopathy, is a late effect of infection from Trypanosomiae cruzi. Chagas remains a serious health problem affecting about 6 million people, mainly in Latin America, but is spreading around the world due to migration of infected patients to North America, Europe, Asia, and Australia. The cardiomyopathy is the most serious complication of Chagas, and it occurs in about 20 to 40% of infections during long-term follow-up. This cardiomyopathy is characterized by myocarditis that can involve all areas of the heart and conduction system. And these patches of scar can also set the stage for terrible episodes of VT. There are thoughts that heart failure due to Chagas may have a higher mortality than standard heart failure. Things like higher rates of pacemakers, stroke, heart failure hospitalizations, and mortality. And to date, there's no evidence to guide therapy in Chagas cardiomyopathy. So the trial design of Parachute compared sacubitril valsartan titrated up to 200 BID versus enalapril titrated up to 10 BID. Patients had to have an EF less than 40% and an increased NT-proBNP, and from now on I'll just say BNP. Chagas had to be confirmed by at least 2 serologic tests. 922 patients were enrolled from 83 sites in South and Central America and Mexico. For context, the Paradigm HF trial enrolled 8,400 patients. Paradise MI enrolled 5,600 patients. Now, before I tell you the endpoint, you're likely thinking there is no way that they can have a typical CV death, heart failure hospitalization to endpoints. And indeed, they did not, and this is a key issue. The primary efficacy endpoint was CV death, first heart failure hospitalization, and reduction in NT-proBNP at week 12. And perhaps even more problematic than that silly biomarker endpoint was the fact that they used a hierarchical ordered composite endpoint with a win ratio. That is, first they compare pairs of patients for CV death. If there's no winner, they go to heart failure hospitalizations. Then if no winner, they go to change in BNP. They screened about 1,800 patients to enroll the 922, so about half were screening failure, mostly for not having a high enough BNP. These were 64-year-old patients, 40% female, 2/3 with class 2 heart failure, 1/3 with class 3 heart failure. The mean left ventricular ejection fraction 30%. And the results: the total wins for sacubitril valsartan 48.5%, total wins for enalapril 31.6%, the win ratio 1.52, confidence intervals 1.28 to 1.82, p-value highly significant. So there you have it. A positive trial for sacubitril valsartan in Chagas cardiomyopathy, And you get the title of the news articles: First Evidence of Treatment Benefit, Positive Results Revealed from the First Prospective Trial in Heart Failure Due to Chagas, and yet another, Sacubitril Valsartan, Effective in Neglected Chagas Cardiomyopathy. But you all know what to do next, right? You look at the components of the primary endpoint. CV death, 11 versus 11.7%, non-significant. Heart failure hospitalizations, 11 versus 12.4%, also non-significant. All the difference came in the BNP results. It went down minus 30 in the sacubitril valsartan group versus minus 5.5 in the enalapril arm. And so the wins in the BNP arm were 22.5% for sacubitril valsartan versus 7.2% for enalapril. Adverse events were not appreciably different, and the conclusion from the slides at the ESC were that sacubitril valsartan was superior to enalapril with respect to the hierarchical composite endpoint of CV death, hospitalization for heart failure, or relative change in proBNP. These results were primarily driven by a reduction of 32% in the adjusted geometric mean of the NT-proBNP levels at week 12. Week 12. And this comment, quote, "There is a need for rigorously conducted clinical trials in Chagas disease to better define the cardiovascular benefit-risk profile of new treatment options for this neglected and high-risk population, and Parachute HF is the first randomized trial to generate high-quality evidence to support a pharmacologic treatment." My comments: I hardly know where to begin. First is the question of Chagas cardiomyopathy is an understudied condition, and the prognosis is tough. It occurs mostly in countries with fewer resources than the U.S., so it's important to empirically study therapies that could help these people. But sadly, Parachute HF is not a good effort. It looks more like a run-of-the-mill pharma-funded marketing exercise, the sadness of which is that vulnerable, cost-constrained populations are being taken advantage of. Also sad is that I know, and you know, that the authors knew what would happen with such a trial. I mean, first they make the same mistake as choosing the wrong comparator, and I say the same mistake as in Paradigm HF. You want to know the effect of adding sacubitril to valsartan, so the obvious comparison is to valsartan at the same dose. Then you would know what sacubitril does. You don't compare it to the lesser dose enalapril. Of course, the authors and the sponsors know that this was one of the core criticisms of Paradigm HF, and they did it anyways. Second problem was that to show a difference in clinically important outcomes, such as hospitalizations or CV death, you will need thousands of patients, and that's not what happened. And actually, I can't say that's anyone's fault, because there just aren't as many Chagas cardiomyopathy patients as there are standard ischemic and non-ischemic cardiomyopathy patients. But that does not excuse choosing a dubious biomarker endpoint. I mean, BNP is a reasonable biomarker for diagnosis. It sometimes helps. But that it was reduced more in the sacubitril arm means next to nothing. But they would have known that before the first patient was experimented on in this trial. Third, had they simply chosen standard CV death or heart failure endpoints, the trial would have been null. It would have been underpowered, yes, but it would have been non-significant. The clinical interpretation would have been that we would have no evidence that the expensive drug was any better than the inexpensive generic ACE inhibitor. But instead, now Novartis can claim one other positive trial for its expensive drug. But if you look past the top-line results, you know that this was an uninformative trial. And it was going to be thus from the beginning. I mean, perhaps the best way to study this question would have been to make it a non-inferiority trial. I just throw this out there. Maybe you disagree. You could say enalapril would be the less costly item than sacubitril valsartan, which I think is a good reason to use it as non-inferiority. And had this been used, both upper bounds of the 95% confidence interval of CV death and heart failure hospitalization were less than 1.3, which is almost always less than the standard non-inferiority margin. Now, I know this is a problematic way to think about it, because you can't say that sacubitril valsartan is the accepted therapy for Chagas cardiomyopathy, but you can at least say that the enalapril for CV death and heart failure hospitalizations, the upper bound, the worst case scenario, was not that much worse. Finally, I have no a priori reason to think that sacubitril valsartan would be any better than an ACE inhibitor or ARB in patients with left ventricular dysfunction with Chagas disease. I hope guideline writers ignore this uninformative trial because it would be awful to further strap cost-challenged health systems in South and Central America by making sacubitril valsartan a Class 1 indication for these patients with Chagas cardiomyopathy. All right, next topic is the DAPA ACT HF-TIMI 68 trial. The title of the news article was Trial Data Support In-Hospital Initiation of SGLT2 Inhibitors for Heart Failure. Now, speaking of science disguised as marketing and spin, let me tell you about this DAPA ACT HF trial. It was simultaneously published in Circulation, and this borders on ridiculous. The rationale and question of this study is, would initiation of DAPA during the inpatient stay for heart failure reduce outcomes at 2 months? 2 months, that's not a misspeak. They randomized about 2,400 patients, age 69, admitted for heart failure, to either get dapagliflozin or placebo while still admitted to the hospital. Then they measured a composite of CV death or worsening heart failure at 2 months. They also said that they would include a, quote, pre-specified meta-analysis of trials studying early initiation of SGLT2 inhibitors. The rationale paper has this sentence, quote, in addition, the primary endpoint will be analyzed using a Bayesian survival model in which a trial-level meta-analysis of data from published trials of SGLT2 inhibitors in patients with acute heart failure will be used as a informative prior distribution. Note the last phrase, will be used as an informative prior. In the main paper published in Circulation, in addition, we aim to combine data from DAPA ACT TIMI 68 with other placebo-controlled trials of in-hospital initiation of SGLT2 inhibitors in hospitalized heart failure patients to generate pooled estimates of treatment effects of SGLT2 inhibitors on early efficacy. It sounds the same, but I think there are subtle differences. Stay tuned. I'll talk more about that. Well, dapagliflozin started in the hospital versus placebo did not prove significantly better. The primary outcome occurred in 10.9% versus 12.7% in the placebo group. That hazard ratio was 0.86, but the confidence intervals were 0.68 to 1.08, the p-value 0.20. Worsening heart failure and CV death were also non-significant. All-cause death had a hazard ratio of 0.66 and an upper bound of 1.00. Hypotension was about the same. And for the win, in the abstract, quote, in a meta-analysis of patients hospitalized for heart failure, SGLT2 inhibitor reduced the early risk of CV death or worsening heart failure, hazard ratio 0.71, p-value 0.012. And all-cause death, hazard ratio 0.57, also significant. And so the conclusions the authors made in-hospital initiation of dapagliflozin did not significantly reduce the risk of cardiovascular death or worsening heart failure through 2 months in hospitalized heart failure patients. However, the totality of randomized clinical trial data suggests that in-hospital initiation of SGLT2 inhibitors may reduce the early risk of CV death or worsening heart failure and all-cause mortality. My comments. My gosh. Look, we already have a Class 1 indication for SGLT2 inhibitors in HFrEF, but these drugs are often the last of the big four agents started, and this is likely because the effect size is smaller, there's minimal to no mortality effect with these drugs, and the cost is higher. But if you're the company, from a profit perspective, if you can get some of these trials to show positive results during inpatient admission, you're likely going to increase market share. You're going to have nice images to bring with the free lunches at the doctor's offices. You're going to create a tailwind of excitement. You're going to say, hey, we got to get these drugs started in the hospital. Who knows, there could even be a quality measure. The problem is that the main results of the DAPA ACT trial, 2,400 patients, were squarely non-significant, albeit with somewhat wide confidence intervals. So what do you do with a non-significant trial? Well, you can just add this non-significant data into a meta-analysis of data from two somewhat similar trials of different SGLT2 drugs, and voila, you have a positive study. Now remember, friends, spin is defined as language that detracts from a non-significant primary endpoint, and I consider this a huge example of spin. The authors also note that in both the DAPA ACT trial and the meta-analysis, all-cause mortality signal is decreased with the early initiation, and the signal appears early. They write that this suggests, quote, early in-hospital initiation has the potential to maximize benefit. Now, they don't raise the possibility that it is noise because the hazard ratio for all-cause death is larger than it is for CV death or heart failure hospitalizations, two of the outcomes that heart failure treatment with SGLT2 inhibitors would be expected to affect. My friends, when all-cause death reduction is greater than the components of outcomes that the drug should reduce, you should not posit another mystery effect of the drug. You should favor noise. How does a heart failure drug reduce non-cardiovascular death? The answer is it doesn't. Now, in addition to the spin problem of using a meta-analysis to get a positive result, I would question the pre-specified nature of this, because in the rationale paper, they say the meta-analysis would be done to make an informative prior distribution. But there was nothing in the final paper that I could find about a Bayesian analysis. They simply used the meta-analysis and said, basically, further data turn the results positive. So in sum, I would lean more heavily on the main trial results, which was that it made no difference to initiate SGLT2 inhibitors as an inpatient. I would start the medicines in the order and timing that a patient can tolerate. I'm not saying that SGLT2 inhibitors don't benefit patients with HFrEF. I'm not saying that. They likely do, but the effect size is going to be less than the ACE inhibitors, the ARBs, beta blockers, and MRAs. The main lesson of this trial, I think, which is similar to the Parachute HF trial, is actually to learn how the proponents of a drug can design and present studies to favor their preferred drug. Nothing here is fraudulent. I'm not saying that at all. I'm just saying it's unseemly and I don't like it. All right, the third topic is the Amalfi trial of AF screening. This week seems to be a dubious trial summary day. I am sad to say that Amalfi is another problematic trial, even though ESC featured it, JAMA published it, and 17 news organizations covered it. The question was to assess the efficacy of AF screening in older people using a 14-day ECG patch. This was a trial done in 27 GP practices in the UK. Patients had to be older than age 65, they had to have a CHADS FAST score greater than 3, and they were randomized to receive and return a patch ECG or not to get one and just get standard care. There were about 2,500 patients in each arm. Now note for context, the Stroke Stop study of AF screening randomized about 30,000 individuals. 2,500 versus 30,000. The primary outcome was the proportion of patients with AF diagnosed in 2.5 years. AF is defined as the presence of at least 30 seconds of continuous AF. Now, before I tell you the results, we have to know, they have to know, the authors know, that numerous trials have shown that AF screening leads to more AF detection and more anticoagulation, and really no significant net effect on outcomes. For instance, the Danish-led Loop trial randomized 6,000 individuals to the always-on ILR screening device or not. Loop found that screening led to 3 times more AFib diagnosis, 2.7 times more oral anticoagulation use, but no significant effect on the reduction of stroke, and a non-significant 26% higher rate of major bleeding in the screened group. So the results of the Amalfi trial. These were 78-year-old adults, about half male and female, median CHADS FAST 4, 84% wore and returned the patch. Now, just the patch results. This isn't the main results, but just what did the patch find? AF was diagnosed in 4.2% of those who returned the patch, slightly more than half, or 55% had an AF burden less than 10%. So the majority picked up low burden AF. And the main result of the Amalfi trial, after 2.5 years, AFib was present in the 6.8% in the intervention group versus 5.4% in the control group. That ratio was 1.26, confidence intervals 1.02 to 1.57, so the p-value was significant, but at 0.03. Now, the mean exposure to oral anticoagulation by 2.5 years was 1.63 months versus 1.14 months, and that was a statistically significant difference, so more anticoagulation as expected. Interesting, though, was that oral anticoagulation prescriptions were given to 14.4 versus 12.8% of the two groups, and that difference did not reach significance. Obviously, oral anticoagulation was a secondary endpoint. Now, there were only 69 versus 64 strokes in the two arms, and the numerically higher stroke rate in the screening arm was not significantly different. The conclusion was that a male-based strategy of sending ECG patches slightly increased the diagnosis of AF. The authors also noted a higher than expected rate of AF diagnosis in the control arm, and that led to finding only minor increases in AF diagnosis between the two groups. So my comments. I'm not sure why the UK team thought this was an important thing to study. I mean, the literature is full and was full of studies showing that if you screen adults for asymptomatic AFib, you find more AFib. It's often short duration AFib, and that is exactly what they found. So I guess it's great to have confirmatory data. This is a confirmatory trial, but this evidence adds little to our knowledge already. I mean, perhaps the most interesting finding is that while the Kaplan-Meier curves of diagnosing AFib show early separation because, of course, the active arm got a 14-day patch right away, but by 2.5 years, the control arm had almost caught up. The control or usual care arm shows a steady linear line with more AFib diagnosed over time. And I think if this study were done today, like tomorrow, the high penetration of smartwatches and things like that would eliminate any advantage of short-term ECG patch monitoring. The larger story here with AFib in 2025 is that AFib now is often a very different condition than it was in the 1990s when anticoagulation trials found benefit. Now we often find short-duration asymptomatic AFib, so-called subclinical AFib, and the LOOP, NOAA, and Artesia trials find little net benefit in treating these short episodes. The reason, of course, is that subclinical AFib confers a very low annual stroke risk. A patient can have a Chagas score of 4, but if all she or he has is a short-duration subclinical AFib episode, the annual stroke risk is only about 1%, which is going to be hard to lower much more with anticoagulation. Now, I did not say that there's no net benefit, because when you put them together, all the trials, NOAA and Artesia and LOOP, you find lower stroke rates and higher bleeding rates, but the argument could be that reducing stroke at the cost of bleeding may be desirable because stroke is usually a more devastating outcome than a bleed. Remember, friends, screening is an admirable way to combat disease, but in practice there are snags. This is what was said in 1965. I just don't think AFib is a very screenable condition. Yes, we can pick it up early, but the early treatments hardly seem to have a net benefit because early AFib is just not that risky proposition. All right, final topic relates to this, and it's about finding the sweet spot of stroke risk threshold for starting DOAC therapy. I mean, this comes up almost every day. Finding that tipping point where we should pull the trigger and recommend oral anticoagulation is one of the hardest questions in cardiology today. Think about it. You don't want the patient to have a stroke, but taking an oral anticoagulation pill for years or decades or forever is not a small thing. I mean, this seems too simple to even say, but I'm going to say it. It is what I tell patients every day in clinic. Oral anticoagulation is not free. It increases the risk of major bleeding in all patients, so you want to have enough stroke risk reduction that it outweighs the increase in bleeding. If the stroke risk is so low that oral anticoagulation can turn almost all to harm. In days of old, it was easier, right? Chagas greater than 2, clinical AFib, there was a net benefit. Now, though, we have the concept of this subclinical short-duration AFib, and this confers a lower annual stroke risk. We also have AF treatments such as AF ablation. Or we have this situation, which I've been seeing some. The patient takes a GLP-1 agonist, he or she loses 25 kilograms and now reports that his AFib is gone. Do we say that this person still has AFib? Can we estimate the stroke risk reduction with 25 kilograms of body weight loss? If they stop their hypertension meds and diabetes meds, can the CHA2DS2-VASc score go from 3 to 1? I'm asking. I do not know the answers to these questions. This week, a team from Finland, led by Konsta Teppo, published a very clever study in CIRC outcomes. Now, even though this study involved math, I really like it because they try to sort out real-world decision-making that we do every day. The question they wanted to sort out is, where is the yearly stroke risk threshold where you get more quality of life years gained than lost by starting anticoagulation? Now, you can't conduct RCTs for every clinical scenario, which means we need to extrapolate from trials, but in real life, there are tons of factors like competing risks and changing risk for both stroke and AF. So the focus of this paper was the lower risk patient with AF, like I just discussed. They developed a Markov decision model to estimate the impact of starting DOACs on quality of life years on a 20 and 5-year time horizon across a range of non-anticoagulated ischemic stroke risks. I know you, like me, may be allergic to things like Markov modeling, but it's not that bad. And here's how I understand it. People have different health statuses. They're well, they're post-stroke, post-bleeding, and they're dead. The probabilities determine whether they'll move from a well into another state depending on evidence. The variables are taking or not taking an oral anticoagulant. The Markov model is like a probability tree that branches out over time. Each monthly cycle, the model asks, what's the chance that this person will have a stroke or bleeding or death? And of course, data from trials and observational studies inform these probabilities. Now, this model also accounts for the quality of life impacts. For instance, a big, massive stroke reduces quality of life more than a small stroke. For this study, the authors assumed that it was a 70-year-old and there are 10,000 patients per decision arm with quality of life estimated at each 0.1% annual stroke risk without anticoagulation. And the inputs to the model were numerous. They included everything that doctors care about, patients care about. Things like major bleeding, hemorrhagic stroke, extracranial bleeding, death, ischemic stroke, severity of stroke. The 3 outcomes they were interested in were stroke, bleeding, and death, which is exactly what we care about when we're deciding on using an anticoagulant or not. Their analysis accounted for the correlation of bleeding and mortality rates with a baseline untreated ischemic stroke risk, and to incorporate this association, they applied linear regression to estimate major bleeding and mortality rates that best fit previously reported values at the different stroke risk levels. As a result, the annual major bleeding and mortality rates without anticoagulation in the model were 0.9% and 3.7% at a 1% annual non-anticoagulated ischemic stroke risk, and 2.2% versus 12% and at a 6% ischemic stroke rate, respectively. Now, they add to the model the data from the anticoagulation trials and the observational studies. They start, of course, with warfarin over placebo because there are no DOAC versus placebo trials, so they have to estimate the effect of DOAC versus no anticoagulation. They also incorporated the recent NOAA and Artesia trials. They then added in utility weights, whereas a bad stroke or an ICH is worse than a small stroke. And the next step is to estimate the net benefit, basically the mean cumulative quality of life years during the 20-year simulation compared between those starting versus not starting anticoagulation. This allows them to find a tipping point of non-treated stroke risk above which DOAC therapy on average results in higher cumulative quality of life years. And the results. Now, the methods are sort of complex, and I've gone on for a while, but the main figure of the results in the CIRC outcomes paper is not. It shows 2 curves. On the y-axis is cumulative quality of life years. On the x-axis is annual untreated stroke risk. The tipping point was 0.65% annual stroke risk. Above that, if your patient is above that, there's a cumulatively higher quality of life years with DOAC, and below that, there is a lower cumulative quality of life years. And that sounds simple, right? But not so much. There is some nuance. Nuance number 1 is the absolute differences. Get this, at non-anticoagulated stroke risk levels of 1%, 2%, and 3%, The mean quality of life gains with DOACs per patient during the 20-year simulation were 0.13, 0.53, and 1, respectively. Note that 0.13 is like a month added over 20 years. That's positive, but 1 month over 20 years is not so much. And it's the same for non-anticoagulated stroke risks less than 0.65%. Here we're talking days of lower quality of life, not months. Nuance number 2 is it's even lower if you look at 5 years. Get this, the quality of life gains with DOAC therapy at non-anticoagulated stroke risk levels of 1, 2, and 3% were 0.01, 0.06, and 0.14 respectively. So even at an annual stroke risk of 3%, DOAC treatment resulted in only 51 days of improved quality of life years over 5 years. They did a probabilistic sensitivity analysis and found that approximately half of the 2,000 simulated iterations favored DOAC treatment and about half favored no anticoagulation therapy. And this is for patients with a non-anticoagulated stroke risk from 0.5 to 0.9%, so around that CHADS-VASc1 number. Thus, instead of a single tipping point, the probabilistic sensitivity analysis revealed a tipping range, aligning with the 0.65% tipping point identified in the main analysis. So below this range, the proportion of simulation resulting in more quality of life years with withholding treatment increased, while above this range, the proportion favoring anticoagulation increased substantially. Anticoagulation was beneficial in over 90% of the simulations when the annual stroke risk exceeded 2.6%. Nuance number 3. It's super hard to know the non-anticoagulated stroke risk. This too is an estimate. The Jean Quinn et al. Study that I'll cite from Circulation found that non-anticoagulated stroke risk varies all over the place. So my comments, I really like this study. I know it's a modeling study, but it uses data from trials and observational studies, and it considers severity of events to give you the idea of A, the tipping point of any benefit in quality of life years, B, the probability of any harm, and a range of probability of benefit as stroke risk increases. We sort of know this qualitatively, but this puts a probability on it. You can use it to discuss with patients, and here I go to Andrew Foy's minimizer-maximizer frame for patients. For the minimizer patient, he or she can look at how close the quality of life year curves are, around 0.65 to 1.5% annual stroke risk untreated, and they can say, no thanks, doc, an increase in a few days over 5 to 20 years is not worth taking a pill every day. But for the maximizer patient, they can look at the analysis and say, yep, I'm in on DOAC for anything above 0.65%. I want to maximize my chance of benefit, and I don't mind taking the pill every day. For those in the middle, it's truly a preference-sensitive decision, and you just have to deal with the uncertainty. And finally, to those who dare ask how much AFib on a monitor warrants anticoagulation, the answer is not known, and I'm afraid it probably never will be known. There's just uncertainty here. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating. This helps other people find us. If you don't agree with something that I said, please send me a note. We'll talk about it. I learn from these. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.